Good afternoon, everybody. So we're on time to start for the next session, and I will ask Olivier Verborgt from Belgium to come to the podium, and he will speak about how the technology can change outcomes in shoulder arthroplasty. Please, Olivier.
Okay, thank you, Lionel and Patrick. All right.
Struggling a little bit to get the presentations on the screen.
Okay, so these are my disclosures. So we have come a long way if we speak about arthroplasty, since the very first one was done on a Parisian baker in the early days for tuberculosis, actually. If we see the history of innovation, many years were dedicated to implants and metal and plastic. But since the years 2010, we're actually moving towards more technology solutions, preoperative planning, patient-specific instrumentation, and nowadays we're all talking about mixed reality, robotics, and artificial intelligence. So it's a very exciting period, I think, in the history of arthroplasty. I think we all agree that 3D planning is now in our practice to stay. We are better prepared to go to our surgery. We try to virtually plan our surgery and try to think what implants and which configuration will be best for your patients instead of doing one implant for all patients. Also, if you want to execute that planning, I think it's been very well shown that PSI guides are there to help you. They're at this point easily available, they're affordable, and they are very accurate. I personally like to use it for anatomic replacements where there's an important glenoid version, retroversion, where I still want to save them from a reverse, and I want to be as accurate as possible and do the eccentric reaming using the specific guides, not only to find the central axis, but also to correct the retroversion. Intraoperative navigation, I think, is the next step, or is a step further, where you intraoperatively navigate the reaming of the glenoid and also the implantation of the glenoid. And this is a movie that I got from Raul Barco, and they have actually published their results that it also is very accurate, within 5 degrees of accuracy in 70% of their cases. Mixed reality is the new kid on the block. It's been so far for me an intraoperative assist to visualize the 3D plan without me having to look at the computer, but I have it in front of my eyes. I can use HoloLens or other glasses, smart glasses, to do that. And also I think one of the nice things is that you can use it to educate people, physiotherapists, nursing, but also young surgeons. It's not really connected to the patient yet, at least the system that I was using, so it's not really a guidance for me, but it's there on the horizon, and there are a few systems out there that are very promising, and they will help you guide or navigate the glenoid pin placement, glenoid reaming depth, and even also the humeral cut. So I think we can agree that today there's a lot of technology in our hands that are better than just standard instrumentation. If you use standard instrumentation, unfortunately, you'll be up to 10 degrees off of what you have planned beforehand. On the other hand, we must agree as well, and we must say that no studies for now has demonstrated improved clinical outcomes. And that's always the problem with technology, that you need a long time before you can prove it. It's going to be another 10 to 15 years. And if you ask me, I'm not going to wait 10 to 15 years before I'm going to use it. The technology is right there, and we just have to trust that if you do it better and more accurate, it should be better. What about robotics? We know from other fields that robots are outperforming humans like anything else. And I'm pretty sure that it's also coming to your OR sooner or later. You may see from your knee colleagues that they've been involved in this much longer than we are. And I looked at, and I skeptically looked at the data that are out there, and there's the same problem. The clinical outcome, blood loss, operative time, hospital length of stay, complications, and clinical outcome are not really better than the standard techniques. But what is true is that in terms of alignment for the knee arthroplasty, the robot does it better than conventional techniques. we can say that robots produce precision and accuracy, meaning they are more consistent for implant position, and also they hit the target for implant position better than when we do it with our standard instrumentation. Does it matter? Yes, of course, I think it matters. And again, I'm not going to wait another 15 years to prove it. It makes sense that if you get it better in and the position is better, the biomechanics will be better, and you will have better outcomes, or at least you will avoid complications like in these patients. For the robots, what is there out there today? There is a ROSA shoulder robot that you may know from your knee colleagues that also now does shoulders. It's only available in the US right now. 135 cases have been done. It is very accurate, and I will show you some preliminary data as well. It's quite easy to use, it's intuitive, and it also helps to acquire your data intraoperatively, and I will come back to that later. They're still working on minimal invasive solutions and soft tissue balancing, but because of course for shoulder that would be the summum. But as you can see here, these are preliminary data from a cadaveric study where accuracy was measured, and it's very close to the target, within 1 degree of accuracy. So the robot is accurate, also in shoulder replacement. I can give you a sneak preview of how it works. It's actually the same robot arm as your knee colleagues will use. It's just a different software and different handles that you put on. Once you have this installed, you have a collaborative mode, which means that you are guiding the robot towards the target, and then the robot does itself, and it finds exactly the right height, the right inclination, and the right version of your humeral cut. Once you have determined that and you're okay with that, you just make the classic humeral cut, the classic humeral osteotomy. And the nice thing is then you can validate with what you want and what you have executed. And this is different than what we're doing right now, because today we only see it on the X-ray the day after. Now you can validate what you have been doing during the surgery, and if necessary, you can change. The same thing goes for the glenoid reaming. Both anatomic and reverse are possible. This is the handle that needs to be installed for the glenoids. It's a one-step reamer, so you ream the central hole, but also the reaming, the corrective reaming, and there is no guide pin, so there's no cannulated guide pin, so that makes the approach much easier. You can come in more from anterior than anything else, which makes it technically also easier than just a standard instrumentation. And again, it helps you in defining or finding the right version, inclination, and reaming depth. And when you're done with the reaming, again, you can validate what you have done and see if that reflects what you have planned preoperatively. So I think definitely a step further in technology. We will see how available it is and how people can pay for this. That's another question, and this is, of course, also for all technologies true. But I think in the end, if you put all the pieces together and you're able to intraoperatively get all this data and then match them to what you have preoperatively planned, and then see your postoperative results and match them together, we'll be more precise in what we do, and we'll have better decision trees for our future arthroplasty patients. Thank you.
So thank you, Olivier. Very interesting communication. Whatever the technology we use for execution of the plan, you can confirm that, number one, the surgeons still have the control of what is planned?
Of course, yes.
And
it's robot-assisted. Huh?
And second, regarding the exposure, even with a robot, you need to be a surgeon to bring the robot in the right place, right?
Absolutely. But also even for PSI guides, as you know, it's not going to change the way you approach to the shoulder. It may be that in some cases, actually the reaming can be done from more an anterior approach, and you do not have to open up the shoulder joint as you do right now. But on the other hand, you don't do your releases properly, and you may end up with a stiff shoulder. So I agree that the approach and the releases should be one part, and then the execution of both the preparation of the humeral and the glenoid sites is done by the robot.
Are there any questions from the audience? So, Olivier, I have one question. You showed nicely all the benefits of the virtual world in shoulder arthroplasty. So what is your recommendation today? What should we use with all these different kinds of technology we have? And what do you think you will recommend in 5 or 10 years?
Well, I can say what I do myself. For easy cases, I still use standard instrumentation, no problem. So probably that's 80% of my practice still.
With planning or without?
With planning, okay. Yes. And then in the difficult cases, for now, I use PSI because it's available. It's quite affordable, and so I'm happy with that. But it's sort of a disappointment in technology once you have those plastic things in your hands. It's not the same as the intraoperative feeling that when you're navigating or using AR, IR, or a robot. I think the true fun and extra addition or added value will come from one of those three. It will also depend on what hospital you work and what your knee colleagues do. It's very difficult to afford a robot if you're only doing shoulders, but if you can combine it with the knee and the hip guys, that's another thing. I think the augmented reality is also a very good solution, but it also comes at a cost. And so it's going to be depending on where you work and how you look at it.
Okay, great. So thank you, Olivier. Yes. We go on with the program and the podium presentations with Vittorio Candela from Italy. And he's talking about the impact of the Coracoid morphometry on internal rotation outcome in patients with cuff tear arthropathy treated with a reverse shoulder arthroplasty.
Good afternoon. Thanks to the moderators. Functional internal rotation remains a concern after RSA. In fact, we know that almost 50% of patients have a persistence of a deficit or even a loss of internal rotation after surgery. From 31 to 64% of patients are not able to wash the opposite shoulder, wash the opposite axilla, use a back pocket, manage toilet, and wash the back. These are all factors associated with an ideal gain of internal rotation. They are all implant-related factors: the overhanging, the lateralization of the center of rotation, the glenosphere size, the humeral thickness, the neck shaft angle, the retroversion, and the functional subscapularis. We know from many studies, these are only the major sample, that the coracoid had a great variability. Our aim was to evaluate the correlation between postoperative internal rotation and coracoid process morphometry, evaluated as glenocoracoid distance in a preoperative 3D CT scan in a consecutive series of patients undergoing the same RS implant. Our background: in all RSA, we have a different degree of distalization, and thanks to the last paper of Professor Gerber, we know that functional internal rotation required at least 40 degrees of shoulder extension. We enrolled 44 consecutive patients admitted to the same RSA implant, and you can see the dimension of the glenosphere for female and males, 145 degrees, zero humeral thickness. Patients with retroversion were excluded. In all patients, short term was excluded, and all patients were submitted to the same post-op protocol. The glenocoracoid distance was measured according to the Dugarte method, influenced by our 3D CT reconstruction. And internal rotation was evaluated with the level of ranging the back and was divided, the patients were divided into two groups, internal rotation according to the 6 point they reached. Results. The study group was finally composed of 40 patients. As you can see, there was an extreme variability between mediolateral and anteroposterior glenocoracoid distance. No correlation was found with age, gender, and BMI. No difference between the preoperative and postoperative internal rotation between patients was found. No correlation between postoperative internal rotation and the unique implant variable that was the glenosphere size. We found a significant correlation between greater internal rotation and low mediolateral gleniocoracoid distance with a cutoff of 23 millimeters and high anteroposterior glenocoracoid distance. So our finding leads to some consideration in the preoperative planning, in the evaluation of internal rotation impingement-free ROM. The coracoid conjoint tendon complex has to be considered in order to furnish some realistic data. And when treating patients with a high mediolateral glenocoracoid distance, and this is our cutoff, do consider a glenoid lateralization in order to obtain a satisfactory internal rotation. Thank you.
Thank you, Vittorio. So what is now your conclusion for the clinical practice? Based on the morphometry of the coracoid, do you take it down for something like a Latarjet, for example, to take it out of the way, or? No, but some ideas of maybe something that we call the reverse trilla. In some cases, we are only make this in a cadaver lab, but our message is that during the preoperative planning, we always see the coracoid morphometry, and in many cases, more than before, we lateralize the glenosphere. This is the...
So does this mean that this preoperative new parameter helps you to identify pre-operatively patients where you finally implant the prosthesis, and when you do the internal rotation, you see actually an impingement of the lesser tuberosity with the conjoint tendon?
Yeah, now we lateralize more the glenosphere in order to avoid this impingement with the coracoid and the conjoint tendon in cases in which the mediolateral glenocoracoid distance is very high. The cutoff in our sample is a low sample size, but the cutoff is 23 millimeters. We consider 20. But now we measure it, and we have better functional internal rotation. The follow-up is 2 years, so it's not long.
So, other questions from the audience? We have enough time to discuss. Any open questions from your side? What do you think? I mean, lateralizing of the base plate or glenosphere is one option. What do you think about to make more posterior version on the base plate itself, or to decrease the size of the glenosphere, switching from 39 for male patients to 36, or for females from 36 to 33? By doing this, you also increase the subcoracoid space, and you may increase internal rotation as well.
Yes, but in our study, the major correlation was with the mediolateral glenocoracoid distance. So this is very true, but in our statistic, it was the mediolateral than the anteroposterior. So now, for the type of implants that we use, we prefer to lateralize with the bone.
So in your inclusion criteria also, there was a humeral version less than 20, is that correct?
Yeah, we exclude. In order, we don't navigate this implant. So in order to have less limits between the preoperative planning and what we do during surgery, we do only a consecutive series of catheter arthroplasty with no glenoid erosion in order to have a normal...
No, I mean during the surgery, how do you control your humeral version? Because we know that the more...
Yeah, in all patients, all humeral version was 0 degree. And
0?
Yeah, we implant at 0 degree of...
Referring to the forearm?
Yeah, relative to the forearm, in order to have the same implant, in order to have an hypothetic impingement-free internal rotation, better internal rotation. But we have to go on with the paper.
And systematic subscap repair.
Yeah, all this series, the subscap was repaired.
Exclusion criteria.
We try to exclude all the confounding factors.
Yes?
Yeah, no. In fact, this is one of the limits of the study, and we want to exclude all the cases in which we can do an error for the version. But of course, we have to do a post-operative CT scan in order to see the version. And I say that this series was not navigated, so maybe.
Can you please stand up and go to the mic because nobody understands you? Go to the mic, please. It's on the side.
So if you look at the version of the glenoid component, do you sometimes adjust from your experience to improve internal rotation to get like 5 degrees or of antiversion in your glenoid component to improve the internal rotation?
In our practice, no. We try to put the glenoid at 0, at neutral, like the CT scan in this series. So, no. And so I don't know if
and what about
the moderators.
The radius of the base plate, you mean?
So do you sometimes adjust put a bit of antiversion in your glenoid component in the positioning to improve your internal rotation? Or you put it always at 0? I'm asking Nathan and you, both of you. Yeah, sorry.
So for me, the glenoid version, I'm aiming at having it between 0 and 10 degrees with, of course, the central fixation. Would it be a peg or screw in the vault?
I agree with what Lionel has said. So first, I look for the best fixation of my central post or screw, whatever I use, and it's no problem for me to accept some degrees of retroversion on the glenoid side. Absolutely not. I like a little bit of retroversion up to 10 degrees for my base plate or for my base plate construct.
But you don't put them in antiversion to improve the internal rotation. That's nothing. Okay.
There's for revision cases, if you use the alternate central line described by Mark Frankel, then you have to. In order to enter the scapula, but for standard cases, usually I don't do that. Okay, we move on. Thank you.
Thank you. So we move on to the next speaker, who is Yannick Krutsen, from the Netherlands, with a trendy topic, reducing our carbon footprint by using reusable navigation in reverse shoulder arthroplasty. Please.
Thank you very much for the introduction. First of all, I would like to thank the organization for selecting our study to be presented here today in Munich. Our study is titled Reducing Our Carbon Footprint by Reusing Reusable Navigation in Reverse Total Shoulder Arthroplasty. And this is the first study comparing the accuracy of freehand navigation with reusable navigation. This is our team of the Venlo Shoulder Unit, and the past year we presented the results a couple of times. And today I would like to present an update of our results. These are our disclosures. Glenoid component positioning in reverse shoulder arthroplasty can be challenging. This is due to limited visualization pre-operative and distorted anatomical landmarks. Nowadays we use the conventional technique, also known as the freehand positioning, and this makes it pretty difficult to place a glenoid component since there is a huge variation in morphology and anatomy, and studies have shown that 40% of the patients have an abnormal glenoid morphology. To overcome this problem, we switched to preoperative planning using the 5D navigation technique. This is a virtual implant positioning, and we use a VIP targeter, and this is an adjustable and reusable instrument with 5 legs, which we use during the operation. That's also where the name comes from. This is a little video. It shows the process of how it works. So we start with the patient. This is the 3D model of the scapula for the preoperative plan. We can adjust and check the measurements. And after everything is approved by the surgeons, we can actually do the surgery. And you can see the VIP targeter. And this is the end result.
What is navigation here?
Even though the main goal of the study is not to reduce our carbon footprint, but by using the 5D reusable instrument, we can reduce our carbon footprint by 16 times compared to a PSI guide, which is a big benefit of using this reusable instrument, but also a big benefit for the planet. The aim of the study is to compare the accuracy and correction of positioning of the gleaned component using the reusable 5D navigation technique compared to the conventional technique. All patients undergoing reverse shoulder arthroplasty are eligible for the study. The only exclusion criteria are primary proximal humerus fractures and revision cases. Below, you can see a brief overview of the timeline of our study, and we follow our patients for the upcoming 2 years with regular set time controls. So we've got 2 groups, the intervention group and the control group. In the intervention group is the timeline below, so all the patients start with a preoperative CT scan. Of this scan, we will make a 3D model of the scapula. Then a preoperative plan is made. This plan is reviewed and approved by the surgeon, and if we approve this, the surgery can take place. And in the control group, we didn't use any form of navigation, of planning. The primary outcome of our study is the radiological positioning of the gleaned component, which we compare the pre- and post-operative CT scans, and we will measure the retroversion according to the Friedman's line and the inclination according to the RSA angle. And the secondary outcome are functional recovery and PROMs, but this is something for later on. We completed the inclusions, and as you may see, we are still waiting for the remaining CT scans. Both groups have 48 people are included, and I would like to focus on this group further on. If we compare both groups, we can see that distribution of gender, age, and diagnosis is the same in both groups, and that in both groups, most of the patients had a cuff tear atrophy as a diagnosis. First of all, we measured the retroversion inclination pre- and post-operative. Based on these results, we calculated the change. And as you can see in the retroversion group, is the same in both groups, but the change in inclination is significantly higher in the 5D navigation group. Next, we also calculated the accuracy of positioning, where we measured the standard or VUP planning versus the actual positioning. The accuracy of the 5D calibrator was defined as the difference between the planned measurements by the software and the actual measurements post-operatively. In other words, deviation of the post-operative values from the planned values. And for the freehand method, we measured the deviation between the standard values and the post-operative measurements. And since we tried to place the implant in a standard position, of a standard position of a neutral retroversion and inclination of both 0 degrees, so we took those measurements as the standard values. These are the results of the accuracy of positioning. For retroversion, the accuracy of the 5D navigation technique is significantly higher. And you can see that the freehand group had a median deviation of 7.8 degrees, and the 5D navigation group of 2.3 degrees. For inclination, the accuracy shows no significant difference compared to the freehand group. But what is noticeable that the interquartal range was for the retroversion and inclination lower compared to the freehand group, but it was not significant. To conclude, there is a greater inclination correction within the 5D navigation group and a more accurate placement of the gleaned component and retroversion. Those results are statistically significant, but what about the clinical relevance? That's something yet to follow, because the secondary outcomes we haven't completed yet. That's about the functionality, and I hope within the past year, well, a year and a half, that I would have all the results together.
Yeah. You want me to do it?
As a take-home message, navigated prosthetic placement is gaining popularity. This is also a sustainable technique. It is a reusable patient-specific instrument. And as you can see, the results are getting better. So navigation and implant placement is recommended. Yeah, what about the future? I can't tell something about the long-term outcomes yet. That's yet to follow. And the biggest question is, can we implement this as a standard care? Are there any questions?
Thank you for this presentation. Just to make it clearer for me, so you compare two groups, one group with the standard instrumentation and one group with the reusable handle, which acts, yes, in fact, as a PSI.
That's correct.
Okay. I didn't get the point where the carbon-free procedure is. I mean, you mentioned this compared to non-reusable technology of PSI in other companies, other industry.
We're not comparing it to the conventional technique, but to a patient-specific instrument, because normally you printed a 3D model of the scapula, then you could measure that freehand. If we get rid of that, then with this new instrument, we get a reduction of 16 times.
Okay, thank you. We switch to the next speaker. It's Philipp Moroder from Zurich, Switzerland, who is talking about large variations in the degree of constraint of reverse shoulder arthroplasty liners between different implant systems.
Thank you, Patrick. Let me just pull up my slides quickly. If you can help me, I'm actually able to manage myself, hopefully. Yeah. All right. So thank you very much for the introduction. I'm going to disclose relevant conflicts of interest. We have been discussing different design parameters for reverse total shoulder arthroplasty in the past, but the design of our liners has not been given much attention, to be honest. So what do we know about the shape of our liners? Yes, they are round concavities, but we also know that biomechanically speaking, the degree of constraint of a liner is the second most important factor for stability of our reverse total shoulder arthroplasties. And this is only second to the joint compression forces, so to muscle contraction. So it seems to be a very important factor, but nonetheless, it seems to have been studied very little in the past literature. So what we did is we looked at different implant systems available on the market, and we wanted to compare the shape and the degree of constraint of these liners, of these systems. So what we did is we used an independent preoperative planning software called Medicat. It's a 3D planning software that includes different companies. It includes currently 13 reverse total shoulder arthroplasty systems, 10 of them with additional constraint liners, and 3 systems had 2 different standard liners that we included in the evaluation process. You can see the different companies on the list on the right bottom side. We validated our measurements using company data. So 3 companies actually gave us the actual measurements of the liners. And so we validated our measurements versus the actually company provided measurements. And we were fairly close, or very close. So we were confident that the data that we were able to provide by means of Medicat are actually valid. Then what we did is we calculated the so-called stability ratio of the liners. What is the stability ratio? The stability ratio is the amount of translational force that can be withstood by a system at a given compression force. And there's actually a formula that we have published in the past that we also validated biomechanically that you can use to calculate the stability ratio of a system based on the radius of the system, so the size of the glenosphere essentially divided by 2, and the depth of the concavity of the liner. And if we do this, you can see that if you plot all the available systems out there for standard liners on this figure chart, you can see that there's a huge difference between the different liners. So let me explain this chart briefly. You can see the lines. This is the different sizes of glenosphere, 33, 36, 39, 42, and 45. And then you can see those oval shapes. This is actually the projection of the stability ratio of the liners of different companies that you can see listed on the right-hand side. And what you can see clearly is there's a huge difference in stability ratio generated by the liner between companies. You might have companies that have 130% stability ratio and others have 200% stability ratio. And what is even more interesting is that some companies keep it constant across sizes, while other companies actually change extensively if you go from a smaller glenosphere to a larger glenosphere. And then there is even some companies who have a downward trend and then an increasing trend again. And if we look at the differences in terms of constraint liners, the whole scatter gets even more extreme. You can see it's all over the place. We have constraint liners of some companies that are the same as standard liners from other companies and vice versa. So there's not a lot of consistency between systems, but also, as I mentioned, not a lot of consistency within systems. As you can see, some of these oval shapes are not horizontal in space, meaning it changes within the system depending on the size. So within the system, we found 4 systems to maintain a stability ratio within 5%. We had one between 5 and 10%, and then we had a considerable number of systems where the stability ratio changed. Some increased with increasing size, many decreased with increasing size, and some actually decreased before increasing again with changing sizes. So in conclusion, we can claim that there is a large variation in the degree of constraint between liners of different reverse total shoulder arthroplasty systems. And more interestingly even, there is large variations in the degree of constraint between liner sizes of the same reverse total shoulder arthroplasty system. Now, we don't know exactly how this translates to clinical reality, but given the consideration that the degree of constraint is the number 2 factor for stability, it might affect stability. On the other hand, it might also be able to affect mobility of the joint. And this is something that seems to be deserving more attention in the future in our research. Thank you very much.
Thank you, Philipp. This is a very interesting study with a potential high impact, especially if you're using multiple systems from different companies. Because if you use a system where you have a very low stability ratio or very high stability ratio, this may explain why you may have dislocations in some cases. Questions from the audience? Interesting and hot topic. What do you think? Can you make conclusions out of your data? What would be like a guideline for designing a liner? Like, let's say, for a kind of high mobility liner, like a standard liner and a constraint liner. How much stability ratio is needed?
So the first conclusion for me is that we need to know. As a surgeon, if you use these implants, whatever company, doesn't really matter, you need to know what you're facing. If you are using a liner that is very shallow, you need to know that as a surgeon, because you might be facing an increased risk of instability. On the other hand, if you use a very constrained liner, you want to know that because it might limit your range of motion. So first thing key is knowledge. And then the second one, which one you would prefer in terms of design? I would prefer everything. You know, I have primary osteoarthritis cases in gentlemen where I would use a liner that is very shallow and gives me potentially more mobility. And at the same time, in many cases, you would like to use maybe a more concave liner. So it depends on the patient-specific attributes that you're facing, and then you can judge. But obviously the companies can only provide you a certain portfolio that is feasible. They cannot give you everything because it's just too costly.
I have one question. What are your specific indications for the retentive liners in the primary arthroplasty patients?
So none.
No.
I don't use them, but in a revision setting, I would actually opt, if it's an instability revision, I would opt for a constraint liner in order to improve my chances of stability, because biomechanically speaking, this is very, very important.
And what about the fracture patients with the reverse?
So I don't use constraint liners, but then again, I use a system that on this chart has a quite high constraint ratio, and for that reason, I don't need a constraint liner.
Okay, thank you so much.
So, Philippe, since you know a little bit more accurately those parameters, given the fact that for, I think, 100% of us, the way to assess intraoperative stability when you just reduce is just based on very subjective feeling of the surgeon himself. Did you change anything? Do you trend to use more deeper socket implants, or did it change something?
So what we trial as surgeons during the surgery is concavity compression. We try to distalize, lateralize, and see how much tension is in the joint. So this is concavity compression. That's the #1 factor. So rightfully, we test for that. In terms of liners, you're very much limited by your system. But I had a case, for example, where I did an APC that dislocated on me using a system that has a very shallow socket. And so when I did the revision, I had them produce a more concave liner as a custom in order to revise this terrible case, and it was working very nicely. So I don't know whether that was the only factor, but I'm surely paying more attention now into which liners I'm using for what case. And I think the companies will do so in the future as well, because this was quite surprising, especially the scatter and the changes within the systems that were not constant.
And maybe last point, regarding what was said this morning, that we know that at the end of the day, most of the mobility after reverse, especially in elevation, is done by the scapulothoracic motion. In fact, what we think is going to get less mobility because of a deeper socket will probably only influence the glenohumeral motion, which at the end of the day is the less important part in the motion.
Completely agree. It makes up for, let's be generous, 50–60% of the motion, so it's definitely not 100%. And then we don't know how a constraint liner and what degree of constraint you need in order to limit your range of motion. We just don't know. I'm just saying it's very interesting to see those huge differences that are almost twofold, sometimes even threefold, between companies and even within systems.
Know your implants.
Yes.
Hello. Okay, thank you very much. Very interesting and enlightening, as usual, with Philip. So we move on to Joseph J. King, who are going to talk about reconnection. Sorry. Acromiale on the influence of os acromiale on patient outcomes after RSA, a match cohort study. Please.
Do I do anything to pull up the talk? All right, thank you guys. I wanted to thank my co-authors for their hard work on this project. We do have some disclosures, but none are related to this talk. So the influence of various acromial pathologies on reverse arthroplasty outcomes is poorly elucidated in the current literature. Incomplete acromial ossification may alter deltoid biomechanics after reverse arthroplasty and may affect clinical outcomes. So the purpose of this study is to compare clinical outcomes of reverse arthroplasty in patients with versus without osteoacromiale to better understand its significance. Our hypothesis is that reverse arthroplasty patients with osteoacromiale have worse range of motion and functional outcomes compared to a matched control group. To do this, we looked at a retrospective review of a prospectively collected single institution database with primary reverse arthroplasty from 2007 to 2021 with a minimum 2-year clinical follow-up. We looked at available imaging studies for an osteoacromiale, and this was done by 3 independent reviewers. Outcomes evaluated were active range of motion, including overhead motion and rotation, as well as multiple outcome scores that are commonly used, and complications. We found 64 osteoacromiale patients, and we matched them in a 1:5 ratio with a cohort of 599 available patients, with a total of 320 matched controls, and we matched to age, gender, pre-op diagnosis, preoperative forward flexion, and preoperative ASCS score. Our results, we found that the osteoacromiale incidence was 9.7% in our cohort, with the most common being a pre-acromion, which was 55% of our cohort. The mesoacromion was 38%, and 8% had a metaacromion. You can see on the table on the right that our demographics were similar between groups, which we expect due to the match cohort, with a mean follow-up of around 5 years. We did have one comorbidity that was slightly more prominent in the control group, which was diabetes compared to the osteoacromiale group, but the rest were the same. So we looked at pre-op and post-op range of motion and outcome scores were similar between the two groups. We did find that strength was slightly better in control groups in both preoperatively and post-operatively. This is only a 1 to 2 pound difference and likely clinically insignificant. For improvements in outcomes, we found no differences in improvement of any range of motion, outcome score, or shoulder strength between the osteoacromiale group and the control group for all outcomes reviewed. Another way to look at this too was the proportion of patients that achieved the minimally clinically important difference or the substantial clinical benefit between the two groups. And again, we found no statistically significant difference in the proportions of these benchmarks between the two different groups. We also evaluated pre-OS patients versus meta and mesoacromial OS patients with the thought that maybe the larger involvement of the acromion might have worse outcomes. However, we found no significant difference in improvements in outcome measures in any of the outcome measures that we reviewed. For complication rate, we found a similar complication rate between both groups, about 12%. We did find a higher acromial stress fracture rate in the osteoacromiale group of 4.7% versus 1.5% in the control group, but this was not statistically significant with a p-value of 0.13. And conversely, we found a higher revision surgery rate in the control group of 4.4% versus 0% in the osteoacromiale group, but again, not statistically significant with a p-value of 0.14. When looking at osteoacromiale in the literature after reverse shoulder arthroplasty, Carbagiani et al. In OGSM of 2020 looked at 45 OS patients compared to 133 non-OS patients, and he found reduced forward flexion of approximately 10 degrees and reduced abduction of 18 degrees with similar constant and subjective shoulder value scores and a similar complication rate. Walsh in 2009 also reviewed 23 OS patients and actually found better constant scores in the OS group, which was average of 68 versus 58, but similar post-op forward flexion and subjective outcomes. Binder also reported on 25 OS patients, which had good outcomes with the ASCS score, forward flexion, external rotation, but a slightly higher complication rate. And Urson had a small study of 10 OS patients, and 23 non-OS patients had similar constant scores, quick dash scores, VAS pain, and range of motion. This is similar to the current study where we had similar range of motion outcome scores as well as similar complications. The limitation of this study is a retrospective review. We did have limited numbers of osteoacromiale patients, which could limit our power, and this might have to do with our complications, where we did find higher acromial stress fracture rate in the OS group, but it was not statistically significant, as well as higher revisions in the control group. We also don't have data on os displacement yet, but we're working on that, and hopefully we'll publish that as well. We also did not evaluate implant design and its effect on osteoacromiale, which might have an effect on acromial stresses. In conclusion, reverse shoulder arthroplasty patients with osteoacromiale achieve similar improvements in range of motion, pain, and function compared to matched controls. So surgeons should not be concerned about inferior outcomes when offering reverse shoulder arthroplasty to patients with an osteoacromiale. Thank you.
Thank you, Joseph. So your recommendation is we should not worry about the os acromiale if it's present.
Yes, that's what we found in this study. We were expecting different results, but that's what we found.
Okay, so let's ask the audience. You have a patient that needs a reverse shoulder arthroplasty. Who is ignoring the os acromiale? Okay, thanks for your support to SECEC. Lionel?
No, just maybe a question about when you say periscapular fracture in the os acromiale group, you mean other than the tilt of the acromial itself?
Yes, we did not evaluate the tilt yet. We're working on that, but that was for true acromial stress fractures.
So
there was 3
apart
cases.
from the non-union?
Yes, they were not, had nothing to do with the os. They were apart from that.
Right, okay.
Do you have questions?
Yes.
Yes.
Yeah, would presence of osteoacromiale change the implant you will choose or the amount of lateralization, or you do the same?
I think if I'm worried about acromial stress fracture from some studies we've seen, I would probably increase humeral lateralization and decrease glenoid lateralization to increase the glenoid moment arm if I was truly worried to decrease stresses on the acromion. But that's just me personally.
Yeah, I think this is supported by the ACS study group, right? Maybe Andy, you can add a comment.
Yeah, thank you for remembering that paper. So a paper just published in JBJS, which showed with a multi-center cohort, about 15 institutions, 21 surgeons, that when we looked at various angles, global lateralization led to more stress fractures. But if you lateralize more on the humeral side, it wasn't, it was actually almost protective. So if you have to lateralize on the humeral side, may make a difference. But I will stress that patient factors, osteoporosis, rheumatoid, rotator cuff arthropathy, were much higher in terms of affecting stress fractures than implant designs by an order of magnitude.
Thank you for clarifying. Okay, thanks. We go on with the final talk by Brian Warner, also from the United States, about virtual assessment of internal rotation in reverse shoulder arthroplasty based on statistical shape models of scapular sizes.
Perfect. All right, well, thank you very much for having me here. I'd like to also thank my co-authors who are all listed here and the members of our research team who did a lot of work to bring this project to fruition. And so for a little bit of background, predicting post-operative range of motion has been very challenging. There's been some papers on it recently, particularly using preoperative planning software to predict rotational range of motion has really not borne out clinically. There's also been several virtual range of motion studies that have attempted to provide guidelines for glenoid component placement, the lateralization of the glenoid component, and also the size of the glenosphere in an attempt to maximize internal rotation. However, the majority of these studies have used a model that's based on either one or very few scapula. And so these previous studies really don't account for variabilities in scapular size, or at least the recommendations that come from these studies in terms of glenoid component positioning and lateralization are based on one or very few scapula. So the goal of this study was to assess impingement-free internal rotation in a virtual reverse shoulder arthroplasty simulation using a statistical shape model based primarily on scapular size. And so a little bit about our statistical shape model. It was taken from a clinical database of over 10,000 CT scans that were obtained for shoulder arthroplasty preoperative planning. The statistical shape model was then created by the research team from these scans, and then a principal component analysis was applied to compute the principal modes of variation of the statistical shape model. As with most SSMs, the mode of size was the primary and first mode. For the study procedures, we used 100 pathologic scapula that were then randomly selected and then analyzed to obtain the 5 different scapula sizes used in the studies. We used the mean size and then 2 standard deviations either direction. Then virtual implantation was performed with the advice of several consulting surgeons, and a single glenosphere size was chosen for each of the different scapula just to reduce some of the variability that we saw. And then glenohumeral range of motion was simulated. And so our primary outcome that we wanted to look at was simulated internal rotations. Those internal rotations simulated at 0 degrees and 60 degrees of abduction. We also wanted to be sure that external rotation wasn't compromised by trying to maximize internal rotation, so we also looked at external rotation at the same degrees of abduction. Impingement was then tested, so glenohumeral range of motion was simulated to the point of impingement. However, we capped the maximum range of motion at 90 degrees in any plane to make it more clinically relevant. And so these graphs are a little bit challenging to interpret, but I'll orient you to these on this page, and then each of the following pages will also line up with it. And so these first 2 graphs look at internal rotation in 0 degrees of abduction. On the vertical axis is the internal rotation, the degrees of internal rotation. The horizontal axis then shows what variable we're looking at, and it's different for each of the panels. Each of the colored lines are for a different standard deviation of scapula size, and then for each scapula size, we fitted the appropriate glenosphere that the surgeons decided on. I would argue that internal rotation at 0 degrees of abduction is a little bit difficult to assess in an impingement type of model because there's impingement pretty quickly. And so that some of the variability that you'll notice in these initial graphs is because they impinge very early on. That being said, you can see there's a lot of difference in the amount of internal rotation between the different scapula sizes, showing how important it is, particularly for internal rotation, to factor scapula size in when determining the appropriate positions. Some of the different positions that we looked at in that first graph you can see on the left is inferior position of the glenosphere, in the middle is lateral position, and then on the far right pane is posterior position. We then fixed those positions in the second graph and looked primarily at lateralization because that was our hypothesis that that would affect it most. I think we learned a little bit more when we looked at internal rotation at 60 degrees of abduction. In either of the 2 graphs, you can see that internal rotation increases with lateralization. So in the graph on the left, lateralization is in the middle pane. What's very interesting to notice from that middle pane, the graph on the left, that's variability looking at the lateral position. You can see that the maximum internal rotation is achieved at different amounts of lateralization for different scapular sizes. And so for the very small scapulas, they maximize their internal rotation very early on in lateralization. So you probably only need somewhere between 2 and 6 millimeters of lateralization for the smaller scapulas. For the larger scapulas, again, for an endpoint primarily of internal rotation, you can see that we really didn't reach a maximum for internal rotation. So this goes up to 12 millimeters, which may not or maybe not clinically relevant, but you can see that there still was no plateau reached. And again, I emphasize that this is a impingement-free range of motion model, and there's other endpoints that would be important, such as stress on the acromion, like we just discussed. When we look at the graph on the right for internal rotation at 60 degrees of abduction, we can see very similar findings where there's different amounts of internal rotation for each of the different scapular sizes. But again, that middle pane where we fix the position with inferior offset, which is where a lot of us typically position our glenosphere, you can see that the internal rotation maximizes pretty early for the smaller scapulas, but doesn't really reach a plateau for larger scapulas. We then, like I mentioned, also wanted to look at external rotation in the same model to make sure that we weren't compromising external rotation based on the changes that we were making to implant position for internal rotation. See that overall, as we increase lateralization or increase the glenosphere position, whether that be inferior or posterior, and move it away from a position of impingement, external rotation also improved. And this is external rotation at 0 degrees of abduction. You can see for the graphs with external rotation at 60 degrees of abduction, all of the scapula sizes reach a maximum amount of external rotation pretty quickly, and so there's very little impingement found for external rotation at 60 degrees of abduction, and so this is not quite as relevant to some of the earlier findings. So in conclusion, in this virtual model, the glenosphere position required to obtain maximum internal rotation varies significantly by scapula size. So for smaller scapula, the maximum internal rotation in adduction was reached with a combination of inferior offset and then somewhere between 0 and 4 millimeters of lateralization. For larger scapula, that number's increased. So the inferior offset was certainly helpful for internal rotation, but larger amounts of lateralization were helpful. When we look at internal rotation and abduction, that also varied by scapula size. And so the maximum internal rotation and abduction was reached in smaller scapula between 4 to 6 millimeters of lateralization, and then in larger scapulas, up to 12 millimeters of lateralization or more. Again, I would leave the caveat here, this is just looking at an impingement-free range of motion model and not looking at some of the complications we were just discussing that also can occur with degrees of lateralization, fixation issues, acromial stress fracture issues. So there's other things that need to be rolled into the model before you can make definitive recommendations. I think it's very important, and this emphasizes the importance of looking at scapula size when making recommendations for glenosphere position when trying to maximize internal rotation. Thank you.
Thanks for this study. Just to be clear, when you speak about impingement in internal rotation, you mean that the computer tells you that the anterior aspect of the reverse on the computer model hits the coracoid process?
Correct. So what the computer does is tell us where it impinges and that it's impinging. A lot of times that can be on the coracoid. Sometimes, depending on the position of the glenosphere, that could be on the anterior scapula, the scapula neck as well. But oftentimes it was coracoid impingement.
Brian, did you include the concept of Philip Moroder, the posture type variations in internal rotation? So meaning if you have a scapular patient type A or type C, for example?
We did not for this. This is kind of version 1, so hopefully that's something we can do. This was primarily looking at glenohumeral range of motion. And so again, when we're looking at the overall package, we need to consider scapular position in space and the starting points. This is starting fixed based on a scapula that has completely neutral posture as opposed to someone who might have different postures. So stay tuned. We'll get Philip involved.
I think this is even more than neutral posture, because, and this is not a criticism of this particular study, because every single software that we all use for planification puts the scapula right this way and the humerus quite this way, which doesn't even respect whatever the posture, the minimum scapulohumeral angle between the relationship between the scapula and the resting position angle we have with the humerus. So this is even more than neutral posture.
I completely agree. Philip has taught me that, and it's something I've started looking at in my own practice and will start implementing in the future. This is primarily just a starting point for this study to look at scapula size, and then we can start implementing these other variables.
Okay, there's one question.
Yeah, great study, Brian. Question, when you saw advantages to lateralization, did you look if there was any change in abduction? So was there a cost to making it more lateral or more inferior or superior?
That's a great question, Andy. We did not for this study. I think the challenge becomes, and I'm sure you publish a lot as well, this already generates about 12 to 14 graphs that you're putting in a paper. And so we're going to look at abduction in another study and the consequences of lateralization with abduction, but it's trying to ask very specific questions for a specific paper. But very good point, and I imagine there are some compromises.
So I think we have no more questions. Thank you, Brian. So we are closing the session, and I would like to ask you to stay seated because we have now the SECEC lecture with a lot of current and past presidents here on stage, and it will be very, very interesting and about the history of SECEC. Thank you.